So a brief overview of cholangiocarcinoma and its pathology. So here in the United States, we see about 5,000 cases of cholangiocarcinoma annually, a little bit less than gallbladder cancers and less than hepatocellular carcinoma. With that said, it's the second most common liver primary. It has an increasing incidence as our population ages. The only cure is surgery, and it has a very high mortality associated with this disease. So what type of cancer is it? And I always get that question from patients. For those of us who may not be medical oncologists, it's important to understand this is an adenocarcinoma. It arises from the bile ducts. So those actual cells that are lining the bile duct have the opportunity to mutate. They then progress to an adenocarcinoma, very similar to hepatocellular carcinoma, which is also an adenocarcinoma, but rather than rising from the bile ducts, that arises from the hepatocytes, right? And then it's important to understand how we categorize cholangiocarcinoma. So the simplest way is it's either intrahepatic or extrahepatic. So it's actually all contained within the liver, or does it extend out to the hilum and down into the common bile duct? So ICC, which is intrahepatic cholangiocarcinomas, usually develop as solid masses. They show up on cross-sectional imaging, and always the question is, did this arise from the bile ducts or did this arise from the hepatocytes? Is it a hepatoma or is it a cholangiocarcinoma? On the other hand, the extrahepatic cholangiocarcinomas develop as either nodular lesions or sclerosing lesions, and I'll show you a picture of that, or papillary growths. So these are growths that arise actually from the bile duct, and we see that. The most common type is the sclerosing cholangiocarcinoma type. Within addition, though, there are papillary and other growth mass type growths. So here's a diagram that actually shows that, and this is out of Nature Reviews. So there's actually 3 different growth patterns to cholangiocarcinomas. You can see all the way on the right, you may see only intraductal growth, so this might not show up at all on cross-sectional imaging, right? So they actually present with obstruction usually in this case for intraductal cholangiocarcinoma, and we perform an ERCP typically in the past. We do brushings, and now I'll show you opportunities in which we can actually map out how much of the duct is involved. On cross-sectional imaging, with the exception of maybe MRI, MRCP, standard CT, it's difficult to see the extent of this disease. And I'll show you later on studies that talk about MRI and MRCP and how we can more precisely determine how much intraductal involvement there is. Periductal will show up as a growth, so this is what we sometimes see on EUS, and we do an FNA from the outside when there's a stent in place, and then mass forming might show up as just a mass in the porta hepatis. So what about the breakdown of this disease? What percentage of these are intrahepatic and what percentage of these are extrahepatic? So this diagram is one of the best that we've seen, and it comes out of the World Journal of Gastroenterology. 5 to 10% of cholangiocarcinomas are located solely within the intrahepatic ducts and within the liver itself. So that's that intrahepatic cholangiocarcinoma. The rest, the vast majority, are actually either in the hilum, which is that hilar disease, which we talk about. And again, that's main duct disease. So when I say main duct, left common hepatic duct, right common hepatic duct, the main common hepatic duct, or the common bile duct. And then a small percentage of them, also about a third of them, can be only within the common bile duct itself. It's really important for us to understand what our surgical colleagues are looking at when they're trying to plan out their surgery, because where the cancer is completely changes what type of operation they would approach this with. What are your risk factors for cholangiocarcinoma? Who is it that we're seeing it in? Those of us at tertiary referral centers see a decent amount of primary sclerosing cholangitis. This is a known risk factor for development of cholangiocarcinoma. We have a PSC clinic where we see patients and follow them and survey them for the possibility of developing this disease. In addition, we actually have a large immigrant population that has intrahepatic bile duct stones, so we've actually come across some of these patients that have a history of intrahepatic stones in the bile ducts, and that actually is a risk factor for cholangiocarcinoma. And then obviously parasitic infections in that same population, if they've had parasitic infections, they also are a risk factor for cholangiocarcinoma. Then obviously as we age, so we see patients who are more elderly and after the age of 65, and they have also that risk factor. Then finally cirrhosis, chemical exposures, and less commonly seen, we see choledococele. So moving on a little bit to biliary anatomy and validated staging. So again, we're really defining this disease as intrahepatic, perihilar, and distal extrahepatic. And what we're going to focus on predominantly in this talk is where SpyGlass, we think, has a significant application in pre-surgical staging. So that's perihilar disease and distal extrahepatic disease. The scope itself, in this case of intrahepatic disease, may not be able to get up to that area, number one. And number two, majority of intrahepatic disease is just staged with cross-sectional imaging and or EUS. So there's a number of different histopathologic classifications that we can use for staging. The staging system that we use most often when we talk about cancers or we present these cases at Tumor Board is TNM staging. So that's the American Joint Commission on Cancer, as well as the Japanese Society of Biliary Surgery. And TNM staging, I'll take you through what that looks like. But a lot of us who have done advanced interventional training or do a lot of ERCP may have heard of bismuth classifications, so we'll walk you through that as well. And then finally, Memorial Sloan Kettering has also done their own classification system looking at biliary and vascular involvement. So TNM staging, this complex chart here has how we work up a patient for TNM stage. For those who don't deal with a lot of cancer, TNM stage is then composited, stages 1 through 4, which is your clinical stage for the patient. And in the cases of foregut cancers, we often try to get a clinical stage, which is a composite of a TNM stage. And as you can see, this can be seen on a combination of cross-sectional imaging, EUS, and or SpyGlass cholangioscopy. It does not address ductal invasion directly, and so that's really important to understand on this. We're really talking about vascular involvement, size of the tumor, and lymph node involvement when we talk about TNM stage. I think we can really add to that in terms of the involvement of the biliary ducts, which is what we aim to show today. Here's the bismuth classification. Many of you have seen these charts before. So essentially there's types 1 through 4, and if you focus over on your left-hand side of your screen or your right hand for you, you can see the bismuth classification drawn out for you. So type 1 would be involving just the common bile duct or the common hepatic duct, and then you go into your types 2 and 3, and that has involvement of the common hepatic duct and going across the hilum, either the left or right side. And we'll show you a case of why it's really important to understand how much, if you have a bilateral disease, how much of each of those ducts is involved, the left main and the right main, going into the radicals. And then finally type 4, which is multifocal intrahepatic disease. So keys to preoperative staging of cholangiocarcinoma. I often get the question, is cholangioscopy replacing EUS in your practice? And I don't think that it does. I think we have a great role for our radiology colleagues to do cross-sectional imaging. I think cholangioscopy is additive and not subtractive from cross-sectional imaging. I also think cholangioscopy adds on to EUS in the cases where EUS is needed for a certain amount of vascular or nodal involvement, right? So with EUS, we can take a look at the surrounding nodes in the portal hepatis. We can FNA those nodes. We can look at the portal vein. Cross-sectional imaging really well defines vascular involvement. MRI, MRCP can also help and add to that. So they're actually complementary. But we're going to focus on is how we walk through this. So first and foremost, we need to know, does the patient have cholangiocarcinoma? We can do that by biopsying within the duct with cholangioscopy, or sometimes with EUS with FNA. Second, we always see, is the patient medically fit for surgery? That's a clinical decision that usually goes through our surgical colleague as well as perhaps pulmonary or cardiology. Then next, we also rule out metastatic disease, and that's best done with cross-sectional imaging after we know a patient has cholangiocarcinoma. That can be with a CT scan and or PET scan or MRI. And then we move forward to look at major vascular involvement, because that's important for planning the surgery and knowing that it's resectable. And again, that's a combination of cross-sectional imaging and or EUS. And finally, what we're going to really emphasize today is how much biliary involvement there is for those diseases that are involving particularly the hilum. And so that really tells us, can we resect these patients, or are they unresectable, which we weren't able to tell before.
I want to reemphasize the importance in our practice of the multidisciplinary care that Dr. Sharma and I provide. We actually share the same clinic. We often see patients on the same day at the same appointment time, and that's really been very important as we manage these complex patients. So just as a little bit of context, historically about 30% of resections that are done for cholangiocarcinoma turn out to be positive margin resections. And that's largely because we do not have a good mechanism for determining the extent of disease preoperatively. What that has meant historically is that surgeons are taking patients to the operating room not really knowing what type of resection is going to be required to rid that patient of disease. That in turn that requires the patient in the OR determine the extent of resection by taking thin slices of the bile duct, sending those for frozen section, and doing that repeatedly until the pathologist tells you that you no longer have cancer in that margin. There's a couple of problems with doing things that way. The first is that there's a limit to the amount of liver you can resect, and you may reach that limit prior to reaching a negative margin. Then you haven't done the patient any good. You're leaving them with cancer in place. Secondly, there's good evidence that for a patient to have a survival benefit, that you need a 1/2 centimeter margin. When you do that sort of serial sectioning and frozen section of thin slices of the bile duct, you don't get 1/2 centimeter margin. You almost always leave more than that. So I hope that what I can leave you with today is some value from our experience, which has told us that high-resolution cholangioscopy can accurately define the extent of disease, and that allows meaningful preoperative planning for me, but also excludes patients that would not have a survival benefit from resection. So really we're talking about three types of operations that we can do for cholangiocarcinoma. First is partial hepatectomy for intrahepatic cholangiocarcinoma without a biliary enteric anastomosis. The second is a partial hepatectomy with a biliary enteric anastomosis, hepaticojejunostomy, for perihilar cholangiocarcinomas, those carcinomas that are near the bifurcation of the bile duct. And the third is for distal duct disease, which is a Whipple or pancreatic head resection. In terms of choosing patients that are appropriate for resection, we need to make sure that the patient's medically fit for surgery, that they do not have distant metastatic disease, that there's no extensive local involvement. That's primarily, we're looking at vascular involvement of the main portal vein or bilateral involvement of the hepatic arteries. And importantly, we need to make sure that when surgery is done, the patient has an adequate functional liver remnant. And typically what we're looking for is 2 contiguous segments that have both good inflow and outflow of blood and adequate bile drainage. So traditionally we've used CT, triphase CT, MRCP, EUS, ERCP to work these patients up preoperatively and gauge the extent of their disease, make a diagnosis. More recently, as we'll talk about today, we're using cholangioscopy. So the radiologic criteria that would deem a patient unresectable for perihilar tumors, those tumors right at the bifurcation, are bilateral duct involvement up to the secondary radicals, so that first branch point within in the liver after the primary branches. Encasement or occlusion of the main portal vein proximal to this bifurcation, so down lower than the bifurcation. If that's invaded by a tumor, then that's a non-resectable patient. Atrophy of one lobe of the liver, telling us that it's not going to be functional after surgery, with contralateral involvement of either the portal vein branch or the biliary ducts up to the secondary radicals. So important, the secondary radicals, if the tumor is that high, that's too high in the liver to do an effective operation and make those biliary anastomosis and expect an R1 resection or R0 resection. Of course, involvement of both hepatic arteries rules out resection also. So radiologic evaluation with high-resolution CT and or PET-CT rules out metastatic disease generally. CT is a good modality to evaluate vascular involvement, both of the veins and the arteries. For intrahepatic disease, cross-sectional imaging gives us an idea of the extent of disease within the liver and whether or not that is bilateral disease. And as most of you guys know, for hepatobiliary disease, EUS can in many ways be informative in working up a patient with a hepatobiliary disease. And in fact, in 2004, one group published their experience with 28 patients and assessed the impact of EUS FNA on patient management. And what they found was that with EUS, in 10 patients, surgery was prevented because they were found to be inoperable based on EUS findings. 8 patients had surgery facilitated because they had a cancer identified that had not been identified by the traditional modalities, more traditional modalities. And 4 patients had benign disease and they avoided surgery. But even with that, as I've been telling you, for cholangiocarcinoma, with all those tools, we still, our algorithms do not serve our patients well sometimes. And so our traditional workup of including multidisciplinary care, laboratory evaluation, cross-sectional imaging, ERCP, and cholangiogram information, that still leaves us with a significant portion of patients who go to surgery potentially not having diagnosis because cytology is not great and not knowing the extent of resection is going to be required for the patient. And the same is true in some cases for distal disease. These algorithms, these complicated algorithms, though it informs our decisions, it doesn't give us a diagnosis, and there's certainly room for improvement. And in fact, there's been no major update to those algorithms by which we care for patients since 2008. And there's no universally accepted preoperative workup because none of our workup is good enough for many patients. And what we're here to talk about today is the fact that we now have high definition cholangioscopy, and to me this is a game changer for a surgeon. So cholangioscopy plays a key role in staging main duct disease. It can give us an idea of the extent of involvement of the left main disease, right main disease, the laterality of that involvement, which of course is important for deciding which side of the liver is going to be removed. It can tell us how that disease is involved in the common duct or the common hepatic duct, the common bile duct. And importantly, studies have shown that modern CT, in modern CT, there's a strong tendency to underestimate the longitudinal extension of tumor growth in distal duct disease, so extrahepatic disease. CT does not give us enough information to know what the extent of surgery needs to be in order to remove that disease. So there's room for more precise measurement of the exact length and involvement of the duct, and cholangioscopy can adequately rule out spread within that duct up into the liver, which would require additional resection, or potentially, if it goes into the secondary radicals, would preclude resection. For perihilar disease, so that disease that's near the bifurcation of the bile duct, radiologic criteria does not have enough sensitivity and specificity to determine the exact degree of secondary radical involvement. We keep mentioning that because that's a key point, and that's really where surgeons get lost in the OR. As you go in and you think you're doing the right thing, you get to a point where you've sort of cut your bridges. You have to take out that section of the liver, but you don't know yet that you've got negative margins, and that's a bad position. It's an uncomfortable position for a surgeon to be in.
I'll talk a little bit about SpyGlass. As we make this transition back from, as Dr. Lowe explained to you, the surgical management, again, I can't emphasize enough that we can add to the body of evidence that we have for preoperative workup. And for patients with perihilar disease, we can avoid some significant pitfalls now that we have a new generation of SpyGlass scope. So the flexibility of our scope now is really important. It lets us get into the left and right main, up those ducts and into secondary, tertiary radicals a lot easier because we've added on flexibility that wasn't there before. Our video is higher quality, and so it's completely integrated in to the actual scope itself. And so flexibility, higher quality visualization in the DS scope has allowed us to really feel comfortable in making the appropriate workup in the diagnosis. And we'll show you direct examples of that where it's very clear. And the learning curve has actually decreased significantly as well. So the scope, if you haven't seen it before, is a single-use scope. It's a disposable scope. It has significant improvements overall in the visualization. You have a good example of what that scope looks like. So it actually goes through the working channel of your duodenoscope, and then you have extra dials as well. And then you can pass a variety of different devices, including biopsy devices for sampling tissue as well. So the high-definition direct visualization is really important for us, and here you can see an example of what a cholangiocarcinoma looks like. It's quite clear, even for those who have not done a lot of cholangioscopy, you can see this intraluminal growth and this villiform pattern with some hypervascularity. So for us, we actually take these pictures and or videos and we bring them to our tumor board. They actually have a meaning to our medical oncologists, radiation oncologists, and our other colleagues who may never have seen or haven't dreamt of having the ability to look within the bile duct before. I think that's really nice, and it also allows us to do precise staging, so we can actually talk about where the tumor starts and where it ends, and we'll show you direct examples of that as well. In addition, we can define biliary strictures to be benign, the extent of those strictures. We can treat biliary stones and find other irregularities that may be precursors to the development of cholangiocarcinoma, particularly in patients who have maybe PSC. So here's an example of the biopsy forceps. So we've moved away from cytology and directly to histology. You're seeing that movement happening now with endoscopic ultrasound, but with the ability of SpyGlass, we can do that within the duct. And we'll show you an example of the significant difference in terms of positive predictive value when you do a histologic biopsy. I think what's also important about histology is, and I keep emphasizing this, we have to look at what our other colleagues who are treating cancer are doing. So you now know that we have immune checkpoint inhibitors that are being used in the lung by our medical oncologists. They require certain types of staining and genetic testing. If we can't get a good histologic sample of these tumors, we'll not be able to follow up if they're go on and progress and get immune checkpoint inhibitors or other types of targeted medical therapies from medical oncology. So we have to get good samples, and that's a big difference. And then finally, we have the applications of electrohydraulic lithotripsy and laser for the destruction of stones. It's not related directly to this talk, but it allows us to move into the realm of therapy. So I really like this slide. This slide gives us an idea of what ERCP with brushing looks like and what that positive predictive value is, which is only 29%, and the combination of cholangioscopy with biopsy. You can see a very large rise in sensitivity and specificity as well. There have been numerous studies that have looked at this, and all of which are in favor of doing directed biopsies with cholangioscopy. A little bit back about ERCP. So the addition of cholangioscopy has not given us a significant rise overall in the amount of complications that we typically see from ERCP. But there is the possibility of translocating some bacteria. So when we use this technique, we actually try not to over distend the bile duct with too much water. We have a combination of water with suction so that the bile duct doesn't get over distended. They don't get some translocation of bacteria. And then coming back to our key points, which have been shown, cholangioscopy really can be used to help us determine which patients are resectable in the setting of perihilar disease and extrahepatic disease, all those who have main duct disease. And I think we've given you a number of examples of how we personally have changed our own management and or pre-surgical planning in a multidisciplinary setting. And so we need to be able to incorporate new technologies. It's probably not enough for us to continue to speak to just one another within our own subspecialty. So interventional endoscopists just speaking to interventional endoscopists, or surgical oncologists speaking to surgical oncologists. We have to come across the table in order to continue to advance cancer care and be state of the art and understand what we each other need and how we can help one another with the types of technologies and techniques that we have. I think this is one of the great examples of that. For us, cholangioscopy is the gold standard for tissue diagnosis, for histology acquisition. For perihilar cholangiocarcinoma, it rules out bilateral secondary radical involvement, which without working with Dr. Lowe, I wouldn't recognize that that's the key importance. And a lot of us who are trained in interventional endoscopy, we're trained very well in all these techniques, but we need to understand what the application of these techniques are to the setting of potentially treating that patient. And so we get that a lot with working very closely with surgeons such as Dr. Lowe. And finally, for extrahepatic disease, I think it really tells us the best longitudinal margins. As Dr. Lowe just showed you in that last case, these margins directly correlate to what he ends up seeing in the operating room and potentially prevents patients from unnecessary surgeries and or helps reduce the morbidity related to the surgery that he performs. So we're going to make a transition to cases, and myself and Dr. Lowe will walk you through these cases as we go. There'll be 3 specific examples that we've shared at our tumor board, patients who have been operated on, and we used SpyGlass for some of the management preoperatively. So this is an example of main duct disease. As you saw, 25 to 30% of patients will have main duct cholangiocarcinoma involving the common bile duct. So this is a 49-year-old who's admitted to our hospital with jaundice, dark urine, epigastric pain over the past 3 weeks. Pain is 3 out of 10, mildly worse with eating. Bilirubin was significantly elevated to 12.6. Other liver enzymes were elevated as well. So one of our GI physicians performed an ERCP. This is a direct example of the slide I showed you before. Identified a suspicious appearing lesion in the common bile duct. That was a tight apical lesion in the distal 1/3 of the duct. Did brushings. Our brushings came back negative for malignant cells. And patient was referred to our interventional endoscopy group for consideration of SpyGlass cholangioscopy to get better biopsies and to also further define this suspected malignant stricture. So here you're seeing that we're removing the stent that was placed on the original ERCP. We then cannulate. We're going to see our initial cholangiogram. And as you'll note on the bottom 1/3 there, there's a tight common bile duct stricture that's seen that was defined on the original ERCP. It does appear that the rest of the duct may be preserved. And now we're inserting our SPY scope. As we insert this high-resolution camera, we usually start on the proximal most extent, so near the level of the bifurcation, up the left or right main, and then slowly retract our scope backwards. And as we retract back, we pay careful attention to all of the biliary mucosa in order to map out what this biliary mucosa looks like. What's interesting is this actual example is exactly how our patients is. We have a common bile duct that's been afflicted by disease. And as Dr. Lowe had mentioned to you before, this would then potentially be a Whipple for cure. And it's really important for us to understand where in the bile duct that's affected. Is that the level of the cystic duct, or is it below that, and is it in the intrapancreatic portion? So here you can see our fluoroscopic position, and we're pulling backwards, and now you're beginning to see a mass arising within the common bile duct, below the level of bifurcation, below the level of the cystic duct, and it's quite clear, even if you've never seen cholangioscopy, this is an abnormal growth. It has that classic villiform pattern intraluminally. You can see there's hypervascularity, which is a hallmark of all cancers. And now you're seeing us push forward those forceps that I spoke of in order to grab histologic samples. And then we actually map out the extent of this cholangiocarcinoma. So we know now that it started below the union of the common hepatic duct and the cystic duct, as I showed you before. That's in the intrapancreatic portion of the common bile duct. And we can show that there's sparing of the last 4 to 5 millimeters of the common bile duct. Here's our exact histology samples. Those show that there's histology from the bile duct that's consistent with adenocarcinoma. It's been stained by our pathologist and reviewed at our tumor board. And so the final diagnosis and stage is cholangiocarcinoma. It was a T1N0 M0 stage 1 involving the common bile duct, and it goes 3 millimeters below the cystic duct takeoff and 4 to 5 millimeters above the ampulla. So I'm going to pause this slide on the treatment plan. So I'm going to hand this over to Dr. Lowe and what that meaning has for him.
So, you know, again, what's important for me is to know what operation I'm going to have to do. The feeling of going to surgery, trying to decide on the fly what surgery is the appropriate surgery, trusting frozen sections, which can be inaccurate, to determine the extent of resection. That's a really uncomfortable place to be in. It's an uncomfortable discussion to have with a family. You know, I may do this surgery, I may do that surgery. So it's really been, in a number of patients, some of which you're seeing here, it's really been valuable. So this was a 71-year-old male who presented to the ER with an abnormal CT scan revealing a mass in the right lobe of the liver and ductal dilation. He had some pruritus, jaundice, dark urine for the week prior, did not have an abdominal pain but had light stool. CT abdomen pelvis showed significant intrahepatic biliary ductal dilation, suggestive of biliary obstruction. Common duct did not appear significantly dilated, and there was an ill-defined mass-like density in the right hepatic lobe. The patient went for an ERCP with brushings and stent placement. He was found to have a tumor extending in the bifurcation and up the right main duct. The left main seemed to have some involvement. Again, the extent of the disease there is not exact. Patient on CT-guided biopsy had a cholangiocarcinoma. He came to see our multidisciplinary team and was presented at tumor board. He was resectable only if the secondary radicals from the left main hepatic duct were not involved. So as we talked about, the sidedness of secondary radical involvement is important. SpyGlass Cholangioscopy was performed to determine resectability, and the questions for that were how much of the left biliary system was involved by tumor. You want to narrate this part? Oops. Sorry. I messed up here.
So you can see we removed the plastic stents and recannulated. This is probably as we first start to use the new generation SpyScope, and you can see there's a stricture very similar to what I'd shown you before with perihilar disease. Common hepatic duct is affected, and it's really difficult to say on an ERCP, is there left and right main involvement, and how much of that involvement there is, which is exactly the question that Dr. Lowe posed in order to know if you can take this person for a right hepatectomy. You cannot have involvement of the secondary radicals. So this is a real challenge to us to be able to say that, hey, we can definitively make this call and it's safe to take patient for a major surgery or not. And it shows you our confidence in our ability to perform really detailed cholangioscopy, which I think is revolutionary for us. And so you're seeing that camera that's inserted up, and these are the secondary radicals in the left main bile duct. I'm going to pause for a second. So as we talked about, and I showed you in prior pictures, this is a patient that has a right intrahepatic lesion and then extension of that cholangiocarcinoma to the bifurcation, and then a little bit of the common hepatic duct. So to remove that, as Dr. Lowe showed before, he could remove those lobes of the right side, but he would only do that if there's some way to anastomose and get drainage with the remaining portion of the left side. And you can't do that if the secondary radicals are involved in the left main. In the past, as he said before, this patient would be taken to the operating room, would get frozen section after frozen section until you do or don't know that that's useful. And now I think we can prevent or allow people to go forward with life-sparing surgeries or prevent the cost and morbidity of that surgery. And so this is what you're seeing an example of. So secondary radicals in the left main bile duct are completely preserved, and you can see they're clean. There's no tumor involvement at all. So with no involvement, we felt that the tumor was potentially resectable. And again, you can see how well the scope flexes up into the left side. So primary radicals of the left main hepatic duct, again, no tumor involvement. So this patient could be reanastomosed if they went for surgery. And then we pull back a little bit more into the left main, and you're going to see the tumor appear in just the main portion of that left main hepatic duct. And here it comes, and you can see that very edge of the tumor. And then we're pulling back into the common hepatic duct, and again, you'll see more tumor extension to the common hepatic duct. So this is the type of additive preoperative planning that we can get. And again, this patient had cross-sectional CT with high-resolution CT scan, had EUS, and had a prior ERCP, but this was absolutely additive to what we did before. And you're seeing a wire placed now, and there was no involvement of the mid or distal common bile duct, which means the pancreas would not need to necessarily be operated on. So again, giving some valuable information back to our surgical colleague.
So that patient had what we call an extended right hepatectomy, so resection of the first portion of the left side main duct and all of the right system with drainage of the left side by a new hepatic enteric anastomosis. So this patient had cholangiocarcinoma limited to the right liver. So with the use of cholangioscopy, we were successfully able to determine anatomy and stage. Patient went for extended right hepatectomy with anastomosis of the left main hepatic duct, and tumor involvement was exactly as predicted by cholangioscopy. Patient had a negative margin resection. So the next patient is a 54-year-old female who was admitted to the hospital with slightly elevated liver enzymes, right upper quadrant ultrasound showing cholelithiasis. She was taken by our ACS service for cholecystectomy, found to have an abnormal appearing gallbladder, which was removed, though it was difficult to remove all of the gallbladder. And it was not a normal gallbladder at surgery. Path of the gallbladder showed a moderate to poorly differentiated adenocarcinoma, positive margins at the gallbladder wall adjacent to the liver bed. Margin at the cystic duct stump was questionable, and we actually ran into this quite a bit. It's a difficult resection. They don't get a clean margin analysis of the gallbladder on the cystic dump. Post-cholecystectomy showed a low, attenuating, regular, heterogeneous mass surrounding the gallbladder fossa. There was 4 by 2.5 centimeters and no evidence of metastases. We took our patient, as we do all of our patients, to our multidisciplinary tumor board. And extended resection of the liver was recommended. Right hepatectomy versus right hepatectomy with Whipple procedure to remove potential disease extending down the duct. Of particular importance, again, was the cystic duct stump and whether or not that contained cancer, because that margin had not been adequately assessed. SpyGlass was valuable in this case in that it gave us the ability to look at the cystic duct stump specifically, looking for cancer. So the cholangioscope was placed, as you've seen in the previous videos, and slowly retracted with careful attention to the cystic duct, common hepatic duct, which were all normal. So this told us that the resection required would not include the common hepatic duct, but just a right hepatectomy to remove the local extension of gallbladder cancer. It's valuable information. Previously, you would have had to resect that common bile duct, do a hepaticojejunostomy, which adds to morbidity, and assess for margins in the postoperative specimen.
So this is a video of exactly that case, right? So what we're doing is we're running a wire up the left vein and into the left system, and you're seeing a cholangiogram that looks essentially normal. But you can see where that cystic duct stump is actually just right here. So you're going to see a magnification of that. And again, we don't see any intrahepatic involvement. And the question that was asked is there any involvement of that cystic duct stump? Is there some cancer there, which would then mean Dr. Lowe would have to do a Whipple in addition to that liver bed resection. And so that's a big difference in the surgery that would involve for the patient and the complexity of the surgery. So we're extending our sphincterotomy here, and you're going to see the SpyGlass put up. When we were originally asked the question, I also wasn't sure would we be able to actually take a really good look at that cystic duct stump and how clean our images would be, and do we feel confident that we could absolutely rule out any involvement of the residual cystic duct stump and the common bile duct to preserve her from having a potential Whipple. But you're going to see it's clear as day, number one, that the right main hepatic duct and the common hepatic duct are completely fine as we retract the scope. And here you're seeing on the fluoroscopic image how well that scope flexes up the right main. And we're pulling back further. I'm getting views now near the bifurcation, the common hepatic duct, and that looks clean as well. We're continuing to pull backwards. And now you're going to see the cystic duct stump orifice, which I'll be honest with you, probably in the original generation of the SpyScope, we didn't get to see nearly as well as this. But you'll see a little bit more. So we'll actually get up close to that cystic duct orifice, and it looks very clean. It looks completely fine. We're even able to actually push a wire forward and actually kind of push back the tissues a little bit and get even a little better look into that cystic duct stump with a lot of confidence and a lot of control over the SpyScope as well, which is quite nice. And so you can see it flexing here. And I'm actually driving out a wire, which is right at the tip of that scope. And here's our wire, and we're pushing it into the residual cystic duct stump, and we're getting an even better look. And you can see that there's absolutely no evidence that we can see of any residual disease at all. These views are remarkable. I mean, there's untreaded territory that we were not able to actually look at in the past. And so you can imagine how this technology is able to allow us to confidently preoperatively stage this patient. And then we take a look at the common bile duct, and again, that's completely preserved. So our outcome here, through direct visualization of the cystic duct and the common bile duct, local invasion of the gallbladder cancer, we knew there wasn't involvement of that common bile duct or cystic duct stump, and the patient was taken by Dr. Lowe for a resection. That resection did not have to involve a Whipple in this case, and the patient ended up having negative margins. So again, another example of how anytime one of the main duct disease, left main, right main, common hepatic duct, or common bile duct, there's a potential for involvement. That's really the key role for cholangioscopy. And the vascular structures are still well defined by the old algorithm of using CT scans and or EUS or other cross-sectional imaging, but we never had these kind of views before. And so to me, that's what's really revolutionary about the preoperative staging for main duct disease. And then we have economic impact. So if this patient actually went for a Whipple, just the cost of the procedure alone, let alone the hospitalization time, right? So there would be extensive increased morbidity related to that hospitalization time as the patient has to recover from a larger surgery.